Well, very good evening to all of you, and good morning and good afternoon to all others who are joining from rest part of the world. Today, we have got two guest speakers. The first one will be Dr. Suprakash Sanyal, and the second guest speaker is Dr. Nazima Gangat. Our first guest speaker, Dr. Suprakash Sanyal from Fortis Hospital, Mumbai, will be speaking to us on Ruxolitinib-based treatment of primary myelofibrosis. And our second guest speaker, Dr. Nazima Gangat from Mayo Clinic, Rochester, USA, speaking to us on JAK2 unmutated erythrocytosis diagnostic and therapeutic approach. This webinar is brought to you by Mumbai Hematology Group, supported by Novartis and Nirvin Life Sciences, and managed by Perfect Square. I thank Mr. Suraj Haldar, Mr. Rahul Deshpande and team Novartis, Mr. Paresh Prabhugaonkar and the team Nirvin, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speakers for the day, Dr. Suprakash Sanyal from Mumbai and Dr. Nazima Gangat from USA. All our discussants who are themselves very eminent hematologists and medical oncologists, and you participants for sparing the Saturday evening, morning, and afternoon. Tomorrow, that is Sunday, 24th of December 2023, from 11:30 a.m. Indian Standard Time onwards, we have again Dr. Suprakash Sanyal from Fortis Hospital, Mumbai, speaking to us on polatuzumab-based treatment for newly diagnosed DLBCL, and followed by we have Colonel Dr. Rajan Kapoor from RNR Army Hospital, Delhi, speaking to us on relapsed DLBCL, challenges and novel treatment. Let me introduce our discussants for the day, and we have a galaxy of them here displayed in alphabetical order. To start with, we have Dr. Abhijit Baheti from Dinanath Mangeshkar Hospital, Pune, Dr. Abhijit Giram from Sahyadri Hospital, Pune, Dr. Aniket Mohite from Jahangir Hospital, Pune, Dr. Ashraful Haq Chaudhary from Dhaka Medical College Hospital, Dhaka, Bangladesh, Dr. Deepika Gupta from Sir Gangaram Hospital, Delhi, Group Captain Dr. Harshit Khurana from Armed Force Medical College, Pune, Dr. Neen Mya Thanda from North Okkalappa General Hospital, Myanmar, Dr. Khalikur Rahman from SGPGI, Lucknow, Dr. Madhura Tanaikar Deshpande from Bharati Vidyapit Medical College and Hospital, Pune, Dr. Mona Vijayaran from SGPGI, Lucknow, Dr. Mukul Agarwal from AIIMS, Delhi, Dr. Navid Tamboli from Mumbai, Dr. Nikhil Kumar from AIIMS, Delhi, Dr. Nitin Dayal from Max Super Specialty Hospital, Saket, Delhi, Colonel Dr. P. Suresh from RNR Army Hospital, Delhi, Dr. Rajat Bajaj from HCG NCHRI Cancer Center, Nagpur, Dr. Riyashma Roshan from SKIMS, Srinagar, Jammu and Kashmir, Dr. Rima Miria Abraham from Amrita Institute of Medical Sciences, Kochi, Kerala, Dr. Rituparna Chetia from AIIMS, Guwahati, Dr. Riya Balikar from Wockhardt Hospital, Nagpur, Colonel Dr. S. Venkateshan from Armed Force Medical College, Pune, Dr. Samir Malinkri from Dinanath Mangeshkar Hospital, Pune, Dr. Sandeep Partake from Bharati Vidyapit Medical College, Pune, Dr. Sandeep Shah from Vedanta Institute of Medical Sciences, Ahmedabad, Dr. Satish Kumar A. from Manipal Hospital, Yashwantpur, Bengaluru, Dr. Swati Sinha from King's George Medical University, Lucknow, Dr. Tufan Dolai from NRS Medical College and Hospital, Kolkata, Dr. Upendra Sharma from Bhagwan Mahavir Cancer Hospital, Jaipur, Dr. Vinod Gunasekaran from Kaveri Hospital, Trichy, Tamil Nadu. Let me introduce our first guest speaker for the day, my friend, very near and dear to me, Dr. Suprakash Sanyal from Fortis Hospital, Mumbai. He doesn't require any introduction, but it's my formal duty to introduce him. Dr. Suprakash Sanyal is a Director of Hematology and BMT Services at Fortis Group of Hospitals, Mumbai. He did his DM in Clinical Hematology from KM Hospital and St. G.S. Medical College, Mumbai. He was awarded the fellowship at Vancouver General Hospital, BC Cancer Agency, Vancouver, Canada, where he specialized and trained himself in all types of hematopoietic stem cell transplantation, leukemia, myeloma, lymphoma, and bone marrow failure syndromes. He is a certified fellow in lymphoma from the BC Cancer Agency, Vancouver, Canada. He has authored and co-authored a large number of peer-reviewed articles in numerous international and national journals. He has participated and delivered various orations and guest lectures across the country. He believes in sharing his knowledge and extensive experience by lecturing many medical students. And today, he's with us, lecturing us on Ruxolitinib-based treatment of primary myelofibrosis. I stop over here. Over to you, Dr. Suprakash Sanyal.
Good evening, and thanking Dr. Amit for the wonderful introduction and setting the tone of the meeting. So I'll be speaking on a very simple topic, which is ruxolitinib-based treatment of primary myelofibrosis. Before going to this talk, one thing is extremely important that before the ruxolitinib era to treat myelofibrosis, and every time in the OPD with the discussion with the patient and so many worries and so many complaints that sometimes it feels that it is better not to treat this disease anymore. So situation was like so bad before the ruxolitinib era. So after ruxolitinib era, the life become definitely much better for both the patients and the doctors who are treating myelofibrosis. So little bit about the myelofibrosis. When you talk about myelofibrosis, so there is early myelofibrosis and overt myelofibrosis, and there is other group of the myeloproliferative neoplasms like a polycythemia vera, essential thrombocythemia. They also, after some time down the line, they can also progress to the myelofibrosis. That is called secondary myelofibrosis. And ultimately, all myelofibrosis over the years, they develop the terminal stage of myelofibrosis because symptoms of splenomegaly, thrombocytopenia, anemia, leukoplastosis, peripheral blast, everything increases over the years. And when the terminal stage of the myelofibrosis happens, the death obviously ensues, and around 18% happens in the bone marrow insufficiency. One third of the patient transformed to acute leukemia, 13% thrombosis, 10% around infections, 17% secondary neoplasia, and 5% of the bleeding. These are the causes of the death in myelofibrosis. Next. So disease progression in myelofibrosis, if you see that evolution from the initial stage to manifestation and the terminal stage. So clinical presentation initial phase from the pronounced high platelet count to low platelet count, no blast to circulating blast in the peripheral blood, no or borderline anemia to frank anemia, no borderline splenomegaly to frank splenomegaly or huge splenomegaly, normal or borderline increased LDH to increased LDH. If you see the pre-fibrotic or early myelofibrosis to advanced myelofibrosis, you can see the morphologically also reticular fibrosis, then followed by collagen fibrosis, and then followed by osteosclerosis. And over the time, if the patient is not treated, their quality of life decreases significantly and eventually they die. That is the natural history of this disease. Next. So when we talk about the myelofibrosis or frank myelofibrosis, predominantly there are three symptoms. One is the progressive constitutional symptoms, which causes decreased quality of life and progressive incapacitation, immobility. Progressively increasing organomegaly and extramedullary hematopoiesis that ultimately can give rise to the MF-related complications, leukemic transformations, progressive cytopenia that also can be contributed to leukemic transformations and sometimes premature death due to infections, bleeding, like that. Short-term problem is the vascular events. So these are the constellation of the myelofibrosis symptoms actually comes from these three entity of the progressive constitutional symptoms, organomegaly, and the cytopenias. Next. So it is a progressive disease. So after 1 year of diagnosis, significantly most patients have anemia, thrombocytopenia, circulating blast, transfusion dependency, constitutional symptoms, and splenomegaly and unfavorable karyotype. If you see at diagnosis and after 1 year of diagnosis, the gap is 365 days. You see all the left numbers and the right numbers are different, and left numbers are lower and the right numbers are more. You can see 38% become hemoglobin, low anemia becomes 64%. You can see the circulating blast in the periphery is 45% more, 66%. So actually, an unfavorable karyotyping become 10% to 18%. Splenomegaly more than 10 centimeter at a diagnosis is 21%. But when you go to after 1 year, you become almost 50%, so almost double. So you can see that all the symptoms and the type and the karyotyping, everything changes dramatically after 1 year of the treatment, after 1 year of the diagnosis of the myelofibrosis. So that is why it is a progressive disease and it has a own natural history. That is the most challenging part of this entity. Next. So whenever you talk about the myelofibrosis, the spleen volume is prognostic for survival. The analysis of the comfort data, we all know that larger baseline spleen volume is correlated with an increased risk of death. And the risk of death was 1.14 times higher for each additional 5 dl in spleen volume at baseline. So this is extremely important. So if your spleen size is more at the diagnosis, you have a little sticky wicket on the front of the myelofibrosis. Next. So early stage myelofibrosis. So when we talk about any disease early stage, it is a common concept. Early stages means it is lighted disease. But in myelofibrosis, the early stage myelofibrosis sometimes has a significant clinical burden. That is very important. So impact of the neoplasm on quality of life, work-related activities of daily life, everything can be very dramatically very different even in the early stage of myelofibrosis. So deep low-risk myelofibrosis patients are moderate to highly symptomatic in 44% of the cases. This is important. And reduction in quality of life and social and working activity is similar in low and high risk categories. That is very important again. Next. So MF is a personalized disease. Next. Next. So you can get a conglomeration of you can get a conglomeration of the symptoms. So a patient may present more than one clinical need at the same time. So it can have a thrombosis, it can have anemia, it can have splenomegaly, it can have thrombocytopenia. So different type of constellations. So that is why we call it a personalized disease. All the patients will not get all the symptoms at a time. Prioritization of the clinical needs may be necessary and may change over time. So sometimes splenomegaly is the challenge, sometimes thrombosis can be the challenge, sometimes bleeding can be the challenge. So challenges varies, goalpost varies in this particular disease. And addressing one clinical need may worsen the other clinical need. So suppose you are trying to treat it with aggressively with thrombosis, and then ultimately you was ended up getting thrombocytopenia. So different type of symptoms can happen when you try to address something and landed up getting other symptoms. So overall, 85%, 86% patients having splenomegaly, constitutional symptoms having 80% patients, anemia 40% patients. So this is the, and thrombocytopenia is 20%. So that is the overall clinical picture of the myelofibrosis. Next. So we always try to do some risk stratification and the prognostication of the disease. We have IPSS scoring, we have a DIPS scoring, and we have a DIPS plus scoring. So IPSS and the DIPS is basically age, constitutional symptoms, hemoglobin, WBC, circulating blast. But when you talk about DIPS plus, what is the plus? The plus is 2. Platelet count is less than 1 lakh, 1 point, and the unfavorable karyotyping. That also comes into the picture. So you are basically incorporating platelet data and the karyotyping data in the myelofibrosis classification. That is called DIPS plus. Next. So there are different type of classification practiced from 1996 onwards on the Lilly leukocytic scoring, IPSS scoring, DIPS scoring, DIPS plus, MIPSS, GPSS, like that. In my center, I follow the DIPS plus plus because which I feel that more easy to follow and more easy to formulate. That is why we use the DIPS plus plus. MIPSS and GIPSS has a lot of molecular data. So that we have not started yet in our day-to-day practice in our clinic. Next. So whenever we call about myelofibrosis, who is the driver mutations and what is the probability? So around 60% patients in myelofibrosis are JAK2 positive, 25% patients are the CALR positive, 8% patients are the MPL mutation positive, and around 10% are the triple negative. And among this, 32% is the AXL1 mutation, 18% is the spliceosome mutation, and 32% is the abnormal karyotype. So it has a lot of prognostic significance. So when we call about a mutational status, the CALR mutations are the best one, and triple negative is the worst one. JAK2 and MPL comes intermediate. And among that, type 1 CALR is better than the type 2 CALR. That is also very important. So when we diagnose myelofibrosis, we always do the mutation analysis that we always do. And at the same time, nowadays we do the NGS that will come in the later part. So if you have a CALR mutation, your median overall survival is around 8 years, but triple negative, your overall survival is around 2.5 years. So there's a significant difference if you are CALR mutated or triple negative mutated. Triple negative. Next. So impact of the driver mutations in both prefibrotic and overt or frank myelofibrosis. So in the both pre-myelofibrosis, the prefibrotic myelofibrosis or overt myelofibrosis, the CALR type 1 mutation was the most favorable. You can see from this graph. And in the pre-myelofibrosis, the triple negative had the worst outcome, but the intermediate outcome was associated with the JAK2 and MPL mutation. Next. So, a little bit about the NCCN guideline of the treatment of the myelofibrosis based on the risk and symptoms and signs. So, low risk, observation, there are limited role, but yes, there are role. Plus minus Ruxolitinib, intermediate one, Ruxolitinib, allogeneic stem cell transplant in very selected group of patients, intermediate two, transplant candidate, allogeneic transplantation, transplant ineligible, symptomatic, Ruxolitinib, anemic, treat like anemia like that. So these are the overall schema of the NCCN guideline of the myelofibrosis management. Next. So this is the ELN 2018 guideline of the management of myelofibrosis. So observation alone for IPSS, DIPS or DIPS plus, low or intermediate one, this patient who lacks significant symptoms and who do not display significant anemia, splenomegaly, leukocytosis, or marked thrombocytosis. That is the thing. Other than Ruxolitinib, there are some role of androgen, there are some role of thalidomide. People use the thalidomide prednisolone combination for the anemia, something like that. So there are different type of treatment which we call best available therapy in our language, or hydroxyurea sometimes used as a cytoreduction. Next. So Ruxolitinib is recommended as a first-line approach for MF-associated splenomegaly in patients with intermediate 2 or high-risk disease. In patients with intermediate 1 risk disease and highly symptomatic splenomegaly, first-line therapy is Ruxolitinib. In other patients with intermediate 1 risk disease and in those with low risk disease in need of therapy for myelofibrosis splenomegaly, hydroxyurea is recommended as first-line therapy, but now this concept is gradually getting changing. We recommend consideration of allogeneic stem cell transplant for all transplant eligible patients with IPSS DIPS plus high or intermediate 2 risk patients. So if I just talk about little bit about the Ruxolitinib and myelofibrosis, the expansion of the Ruxolitinib treatment is gradually increasing and encroaching in both lower risk disease as well as the high risk disease. When you are thinking about the transplant, that is one option, curative options, no doubt about that. If you are not transplanting the patient, constitutional symptoms, splenomegaly, cytopenia, overall survival you want, then everywhere the role of the Ruxolitinib is expanding like anything. So it is a little older one, ELN classification, but now the Ruxolitinib is coming in a big way and is expanding its scopes in the all form of myelofibrosis. That is very important. Next. So what Ruxolitinib does is dramatic picture. Pre-Ruxolitinib therapy and after 2 months of therapy. Next. So Ruxolitinib reduces splenomegaly in 97% of the patients. So patient with measurable spleen reduction after 48 weeks of therapy, a follow-up is 97% versus 56% of the best available therapy. That is the power of the Ruxolitinib. So Ruxolitinib basically decreases the spleen size, which actually increases the patient's quality of life significantly. Hypersplenism significantly decreased, and the patient's cytopenia also started improving. So Ruxolitinib is a very, very important drug which actually causes a significant amount of decreasing the splenomegaly and improving quality of life patient significantly. Next. So Ruxolitinib rapidly reduces splenomegaly and the maintained results over time. So it is not only reduces the spleen drastically, but reduced spleen actually maintained. So maintenance of the spleen size is also a very important game of the Ruxolitinib. Next. So comfort one study, we have seen that the patient originally randomized to ruxolitinib arm, around 60%, which is 92 patients in the 155 group, had achieved a more than 35% reduction in the spleen volume at any time during the study, and 50% of the responding patient maintaining the response at 5 years. So that is very important. So maintenance of the good spleen size, that is the ruxolitinib, another very important job. Next. So ruxolitinib treatment has a lot of metabolic and nutritional parameters in patients of myelofibrosis comfort one. So serum albumin stabilizes, which decreases the anasarca, which decreases the pedal. So a lot of serum albumin gets stabilized and improving the patient quality of life. And most important, whenever we start the patient with ruxolitinib, their constitutional symptoms goes down, their patients are eating much better, and their patients' body weight started gaining. So serum albumin, body weight, these are the parameters we studied in the comfort one, but ruxolitinib has a tremendous role to maintaining good albumin, maintaining good body weight, and stabilizing these parameters. Next. So long-term survival in ruxolitinib treatment patients with the comfort 1 and comfort 2 pooled analysis. So risk of death reduced by 30% in patient randomized to ruxolitinib versus control. So median overall survival ruxolitinib versus control is 5.3 to 3.8 years, which is significant. Next. So you can see here, again, the survival advantage was more pronounced for patients originally randomized to ruxolitinib versus crossover patients. So it means the patients who are on ruxolitinib on the day one, they did much better. So ruxolitinib is definitely helps in the survival benefit in the myelofibrosis. Next. So overall survival improves with the spleen size reduction in patients receiving ruxolitinib. That is very evident from this clinical data. So if you say less than 20% spleen reduction, or is it 25 to 50, or the more than 50%, you can see the difference in the patient survival. Next. So effects of ruxolitinib therapy on the bone marrow morphology. The change in myelofibrosis over time. So patients' fibrosis actually comes down. Patient hematopoiesis is getting more robust in the marrow, and that way patient cytopenia improves with the effect of the ruxolitinib. Next. So you can see in the comfort 1 and comfort 2 pooled analysis long-term overall survival of this group. So patient with intermediate 2 risk had longer overall survival with ruxolitinib versus high risk patient. Next. So ruxolitinib improves renal function. So retrospective analysis of patients with previously untreated myelofibrosis receiving first-line ruxolitinib at MD Anderson in July 2004 to November 2001 showed a significant amount of renal parameters improvement happened. The patient who treated with ruxolitinib versus match control. Next. So there is a tremendous impact on the ruxolitinib on anemia and thrombocytopenia. So one point is very important. When you start ruxolitinib, initially there can be drop in hemoglobin that we all know, but it does not mean there is a progression of disease is happening. And it happens, but after 2 to 3 months time, the hemoglobin started slowly become more stabilized, and the patient started improving dramatically. So initially there can be some little bit panic. You started the doctor this drug, my hemoglobin is going down. He may need some transfusion support. He may need some erythropoietin or erythropoietin support. But most patients died over this crisis, and their hemoglobin slowly over the time gets stabilized. Next. So ruxolitinib overcomes the prognostic effect of anemia and myelofibrosis. So what I told in last slide, the anemia worsening caused by ruxolitinib initial days is not a signal of myelofibrosis progression and shorter life expectations. Next. So rationale for earlier use of ruxolitinib. So retrospective study of patients with myelofibrosis treated with ruxolitinib in a line, the guideline at 18 Italian hematology centers. So influence of disease state and quality of response. So more advanced disease and later treatment start may reduce ruxolitinib efficacy. I seen many of my junior colleagues when they got a diagnosis of myelofibrosis, they try to manage with hydroxyurea, They try to manage with other supportive therapy. They try to manage with the immunomodulator sometimes and bring ruxolitinib later part of the treatment. If you bring ruxolitinib later part of the treatment, your results may not be very great. Spleen or symptoms response is lower if your interval between the myelofibrosis diagnosis and ruxolitinib starts more than 2 years. Larger splenomegaly and higher TSS, transfusion dependency and a lower platelet count, and intermediate to and high risk IPSS group. So influence of ruxolitinib dose, early MF patient may tolerate a higher ruxolitinib dose. The patients starting with higher doses have a higher rate of splenic response. And the use of lower ruxolitinib doses may also result in reduced efficacy. So very simple, when you diagnose myelofibrosis, bring ruxolitinib as quick as possible in your treatment algorithm. That helps the patient and that gives you so many benefits. What ruxolitinib will not help you? Ruxolitinib cannot prevent the thromboembolic manifestation, and ruxolitinib though increases the overall lifespan, but it does not have any effect on the natural history of the disease of myelofibrosis that I explained earlier. Next. A few tips of the using ruxolitinib indicated for splenomegaly or constitutional symptoms, regardless of a risk of death. Anemia is not a contraindication. And please avoid prophylactic underdosing. Maintain maximum tolerated dose to achieve larger reduction of splenomegaly early during treatment. Follow platelet count and accordingly you put the dose. Development of anemia does not affect benefit of JAK2 inhibitors. Manage anemia as alternate to early dose reductions. Avoid abrupt interruption of ruxolitinib in patient responding well. So patient is doing well, constitutional symptom gone down, splenomegaly is doing very well. Please don't stop the dose and please follow the platelet count for the dose. Don't just patient is doing well, decrease the dose of ruxolitinib. Please don't do that. Be aware of rare possibility of opportunistic infection. Yes, it is there. In my clinical experience, we encountered so far 4 patients of ruxolitinib having tuberculosis, starting from single organ like a lymph node tuberculosis or tuberculosis lymphadenitis from disseminated tuberculosis. In these cases, with our ID physician consultancy, we managed with a little bit lower dose of ruxolitinib and with AKT. When the AKT started working, we actually again full-blown ruxolitinib we used. The isolated organ tuberculosis, we generally do not change the ruxolitinib doses. So we are just writing a paper on this, so I'll publish it soon. Monitor of the skin cancer in ruxolitinib, that is also an important thing. Next. So mutations in myelofibrosis, number and combinations. So now you do the NGS, we get so many mutations in the myelofibrosis in the background, and the AXL1 plus CALR in the myelofibrosis is the worst combination. That is very important. And if there is a more mutations, that your prognosis is getting more worse. Next. So in a myelofibrosis patient, less than 2 mutations had 9-fold higher odds of a splenic response than those with more than 3 mutations. And myelofibrosis patients with more than 3 mutations also had a shorter term to treatment discontinuation and shorter overall survival than those with fewer mutations. So definitely the mutation impacts the prognosis, and that is why I think the newer classification beyond DIPS is getting important in myelofibrosis prognostication. Next. So hemoglobin level over time by ruxolitinib, how it stabilized. So you can see a dip here, and then over the time it gets stabilized after 2 to 3 months of time. Next. So overall survival analysis by the JAK2 mutation status. So if it's a myelofibrosis, whether your patient is JAK2 positive or JAK2 negative, but ruxolitinib works. Next. So I just present one case study, very small one. So it's a 58-year-old gentleman came to our liver transplant unit with a diagnosis of chronic liver disease from Raipur and having symptoms of last 8 months. And they actually came to our center for liver transplantation. No history of alcohol intake, history of significant loss of weight, around 20 kg in last 6 months. He had an episode of massive hepatocytosis after admission to our institute. We just stabilized him with the active varices but tackled endoscopically. Next. So it is a CT scan, there is a hepatosplenomegaly, and there is a chronic portal vein thrombosis with portal hypertension. Next. So at this point, he was referred to hematology for management of the thrombocytopenia basically. And this is the peripheral smear. Hemoglobin is 6.8, WBC is 14,500, PET is 65,000. There's a classical leukocytic blood picture. LDH is quite high, 978. ANA was negative, viral marker was negative. Next. And we did the marrow state away. Next. So this is the classical marrow. You can see the myelofibrosis, doing grade 3 fibrosis. Very classical of the primary myelofibrosis here. Next. Next. So we did the JAK2. JAK2 is positive. Just go back. Kalpesh, go back. So it's a JAK2 positive primary myelofibrosis. It is not a chronic liver disease anymore. The portal venous thrombosis with portal hypertension explained by the massive splenomegaly. We didn't find any additional mutation at the baseline by the NGS. So we classified the disease as a deep stage 2, intermediate 2. So liver transplant was totally back burner now. And we discussed the patient of the bone marrow transplant option after general condition improves. So next. So we started this patient with the portal hypertension management with the addition of carvedilol and diuretics. We started JAK2 inhibitor stage away, Ruxolitinib, in view of the constitutional symptoms and massive splenomegaly. Doses were titrated as per the platelet counts. So we all know that if your platelet count is less than 1 lakh, more than 50,000, your dose will be around 5 milligrams BD. If it is 1 lakh to 2 lakh, your dose can be 10 milligram BD or 15 milligram BD. But if your platelet count is more than 2 lakh, your dose will be 20 milligram BD straightforward. Less than 50,000, generally we don't use Ruxolitinib. Gradually, his condition improved after starting the Ruxolitinib, and patient was able to return to hometown after a month. He was very sick when we see him the first time. Next. So after 1 month, patient symptomatically better, appetite improved, no further episode of hematemesis. After 6 months, significant improvement in symptoms. Weight gain of 8 kilo happened. He lost 20 kilo of weight in a 6 months time, and in another 6 months, 8 kilo of the weight gain happened. Clinically reduced hepatosplenomegaly, platelet count improved to 1 lakh, and we adjusted the Zakavi according to the platelet count. Next. So in our institute, we do the CT screen volumetry. My radiologist, Dr. Bhargav, was very good in that. So for this particular patient, you can see from here very clearly, the CT screen volumetry, it was initially 4870 ml, and it has come down after 6 months of therapy, 1640 ml. So almost 2/3 of the reduction. And that is the power of the Ruxolitinib in managing the splenic response in myelofibrosis, which gives not only the constitutional symptoms benefit, also oral survival that I discussed. Thank you.
Thank you, Dr. Sanyal, for that wonderful lecture. It was excellent. And I now request all our discussants to please put the raise hand sign so that we can start some Q&A session with Dr. Sanyal. Kalpesh, if you can stop sharing the screen, please. So, any discussants want to ask any question to Dr. Sanyal? Yes. So, Dr. Sandeep, your question, please.
Yeah, thank you, Dr. Sanyal. It was an excellent lecture. I just want to ask you, like initially, sometimes it is difficult to differentiate, pre-fibrotic PMF versus other MPDs. So what is your approach?
So you are talking about a cellular phase myelofibrosis with sometimes PV or something like that?
Yeah, pre-fibrotic PMF or very early stage PMF versus other MPDs, and how do we differentiate, and what are the practical implications of it?
Yeah, so you need a very smart hematopathologist for that. So yes, there are gray area, but the gray area is shrinking. That is most important thing. So as soon as clinically I have got a feel that it's a myelofibrosis, it is not something else. I try to bring ruxolitinib as early as my treatment algorithm. Initially, if the count is too good, so like 14, 15 hemoglobin, WBC is very robust, platelet count is very robust, and you are not very sure what you are dealing. You just labeled as a JAK2 positive MPN. They are a little bit hydroxyuria and all these things. We try and observe the patient very closely. But if it is myelofibrosis, I shown one picture, if you remember correctly, my third slide or fourth slide. Myelofibrosis is a progressive disease. And 1 year, all the symptoms of myelofibrosis, like a constitutional symptoms, anemia, thrombocytopenia, will be significantly deteriorated, right?
Okay.
So if I feel clinically, so I go very much clinically. So if I feel, see, polycythemia vera or ET, these are not very problematic disease even 2-3 years after the treatment. So in myelofibrosis, you will understand, you get a clinical pulse, you get a clinical feel. It's a completely clinical feel that yes, you are dealing with the early stage of myelofibrosis. And if I believe it's a myelofibrosis, I try to bring that ruxolitinib as early as possible because I know that it's the only drug which can change the patient destiny.
Okay. Another thing I wanted to ask is the role of quantitative JAK2 mutation.
So this discussion done lot of times in lot of forums. So positive, negative, only that matters. The allelic burden has no role in deciding any therapy or anything. At present, clinically, it has no much value.
Okay, like over in a single patient monitoring over time, does it help? Like whether it is increasing?
I don't believe so. I don't believe that.
Okay, thanks. Thank you.
At this point, we discussed a lot of times. Initially, we are very excited about the starting ruxolitinib, whether the allelic burden is coming down or not. I have one slide of allelic burden. I have not shown because of the time constraint, but I think that is back burden now.
Okay, thank you.
Thank you, Dr. Sandeep. Dr. Upendra Sharma, your question, please. Dr. Upendra Sharma.
Thanks, Dr. Sanyal, for that wonderful presentation. So sometimes we have patients of myelofibrosis who have the blast count, say, between 10-15%, say, extended phase of myelofibrosis, not transferred to AML. So how do you approach those patients?
So 10 to 15% blast in myelofibrosis means it's a very advanced disease, right? So it is transforming. It is transforming. So today you are not calling it AML, but tomorrow you'll be calling it AML anyway.
So we can say it's an accelerated phase of myelofibrosis, no patients.
So it is basically one form of secondary AML. It is one form of secondary AML. So whenever secondary AML, by definition, secondary AML is a very bad disease, poor risk disease. So here my choice will be always the azacitidine venetoclax combination.
Sometimes we have, Dr. Amit, can I ask another question?
Yes, sir. Please, sir.
Yes, sure, you can always ask.
So sometimes we have patients of myelofibrosis who have big spleen. They present with, say, platelet count between 40-50,000. So sometimes we are hesitant to start ruxolitinib. So I have a few patients wherein I've started ruxolitinib. They are maintaining their platelet count between 40-50,000. Blast, peripheral blood 1%. Patient having symptomatic better. Spleen size is somewhat reduced. Not that much significant response. So how do you see those patients? So what is the exact cutoff is 50,000, but how you feel about those patients?
So, Dr. Upendra, shall I be very honest to you? Yeah.
Yes.
So if 30,000, 45,000, 35,000, these are the platelet count I see. And I see a big spleen. I start ruxolitinib. I'm very honest to you. I talk with the patient. Yes, this is the data, 50,000 here, but we start the patient. Yes, I start. And most of the time, I am the winner. So after some time, I see the platelet count started rising to 60,000, 70,000 right there. So then officially I get a permission. Okay, I can use. So I use, yes. One patient I can tell you who had extremely bad constitutional symptoms and very bad splenomegaly, a huge splenomegaly. And that patient he followed with me almost 6.5 years. So when the platelet count actually came down to 25,000, 30,000, then he told me, the doctor, Only thing, my constitutional symptoms are not very significant. I have a big spleen, I have a problem, my platelet count is low. So please don't stop my ruxolitinib. It is my responsibility that if something happens, no one will sue you. He told me like this. So one thing I realized, when you start myelofibrosis and ruxolitinib, the group of patients, the cohort of patients who actually get the benefit of the constitutional symptoms, their quality of life changes. They love ruxolitinib. They don't want allow you to stop ruxolitinib. So I told you, ruxolitinib does three things: constitutional symptoms, splenomegaly, and stabilizing of cytopenia. But among all this, if you remember, when we are students, like we were going together in the KM, so when we are students, with those ruxolitinib, what we used to write? Hydroxyurea, 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 give some thalidomide, prednisolone, and every time there were a lot of complaints. I started my talk like that. Our ears are so frustrating that one point of time you say, okay, enough happens, I just stop treating myelofibrosis. But that era has gone. So my personal view is, don't stick to 50,000 criteria. If the patient is comfortable, you start and see what happens. But when you start, only thing you have to
What is
follow,
the
sir,
then what is the lowest platelet count where you will stop the hydroxyurea? You will stop ruxolitinib?
I'll be very skeptical to keep ruxolitinib below 25,000 platelet count. But little borderline, what you were talking, 40,000, 45,000, I'm okay to start. I'm okay to start.
Thank you.
I did lot of, and most, I'm telling you, I'm very confident, I'm telling you, I'm the winner most of the time.
Thank you.
Thank you, Dr. Upendra Sharma.
What you do? What you do, Upendra?
So, just as you told, for few of those patients, I asked them that, yes, I counsel those patients. Yes, they see literature says 50,000, less than 50,000, there is risk of bleeding, but we don't have much options. So this is a good drug. If you're benefiting, we'll closely monitor your platelet count. If you have any bleeding symptoms or platelet count goes further down, then we have no other choice. We'll stop ruxolitinib. But these patients, somehow they maintain their platelet count will say more than 35,000, 40, 50 constitutional symptoms, and some over the period of time their platelet count further increases. So initially we are very hesitant, but now we start with less than 50,000 also for our patients.
You know, my logic is, if your splenic size gets reduced, your morphology of the marrow gets improved from fibrosis to fibrosis. So your cytopenia definitely improves. That is my logic. And this is the only drug.
So there is some element of hypersplenism in those patients. So there is some element of hypersplenism in those patients, and that when spleen size decreases, then platelet count further improves both because of the marrow improvement of the marrow function and decrease in the size of the spleen.
Absolutely, absolutely.
Thank you.
Thank you, Dr. Upendra Sharma. Dr. Rima Miria Abraham.
Yes, sir. Sir, I had a doubt. How would you go about JAK negative myelofibrosis?
Yeah. So I told you in my slide that 60% of the JAK2 positive myelofibrosis, around 25% of the CALR positive, 8% is a MPL mutated myelofibrosis, and 10% is a triple negative. So if you know that it's a triple negative myelofibrosis, so myelofibrosis diagnosis is straightforward. So you do the blood work, leukoerythrocytosis picture, splenomegaly, high LDH, rule out the other causes of the myelofibrosis. Though your JAK2, MPL, CALR all negative, marrow shows marrow biopsy. You need a very good hematopathologist. I'm telling you, that is very important here. If you're a good hematopathologist, he says, okay, it is a myelofibrosis. So then it is triple negative myelofibrosis. So it is not like a CML where the BCR-ABL positive, you can use the imatinib. If not, you can't. So JAK2 negative myelofibrosis, ruxolitinib also works equally, with the equal benefit you will get in the JAK2 negative myelofibrosis also. So that is the way you have to diagnose JAK2 negative myelofibrosis. And 40% myelofibrosis are JAK2 negative, remember that.
Okay, sir.
Only 40% are JAK2 positive.
Okay, sir. So if the MPN reflex panel is negative, do you always go ahead with a sequencing, sir? Do you?
It's a good question. So what you do, I always do the JAK2, CALR, MPL first shot. And if you negative, we diagnose myelofibrosis, and then I do NGS. Yes, I do. I do NGS routinely nowadays in myelofibrosis because, you know, I've shown some slides, right? Like a driver mutation. There are some other, so if your mutations are 4, just 2 mutations, 3 mutations or more. So
Yes.
then future prognosis is poorer. So I have one patient who is a CALR mutation positive, but at the same time, he's a XL1 mutation is also there. So I told you CALR1 and XL1 is a very bad type of prognostication. So this patient needs transplantation counseling upfront. So you need to know all these things. So you see some of the CALR people were very good, but some of the CALR is not doing well. So that means some hidden mutation in the background. So I think these are very important in 2023. You have to understand the disease biology more wide way so that you can plan the therapy in a more directed to the patient benefit. Yeah.
Thank you, sir.
Thank you. So that was the end of our first lecture, the question answer session. Thank you, Dr. Suprakash, for a wonderful lecture, amazing lecture, and what a wonderful discussion. Thank you so much for being with us. We have our second lecture waiting. So we'll go with our second lecture. Let me share the screen again. So now it's the time to introduce our second guest speaker for the day. We have with us Dr. Nazima Gangat from Mayo Clinic, Rochester, USA. Dr. Nazima Gangat is a professor of medicine with the Division of Hematology at the Mayo Clinic, Rochester, Minnesota. She received her medical degree from Aga Khan University, Karachi, followed by internal medicine and hematology training at the Mayo Clinic before joining as faculty in 2012. She currently serves as the Education Chair, Division of Hematology and Program Director for the Advanced Hematology Fellowship Program. She was named as Teacher of the Year by the Hematology Fellows in 2016, 2020, and 2021. Her clinical and research interests are focused on myeloproliferative neoplasms. She has authored and co-authored over 100 papers and key contributions to the MPN field, including improving prognostication, investigation the connection between mutations and clinical phenotype, and evaluating novel therapeutics. She has served as editor-in-chief of the American Society of Hematology News Daily from 2020 to 2021. She is currently an associate editor for Blood Cancer Journal and editorial board member of the American Journal of Hematology. Today, she is going to lecture us on JAK2 unmutated erythrocytosis, diagnostic and therapeutic approach. Well, thank you so much. Over to you, Dr. Nazima Gangat.
Hi, good evening, everyone. I'm going to go ahead and share my screen. Let's see. That look okay to everyone?
Absolutely perfect. Please go ahead.
Perfect. So we're going to go ahead and get started. So I'm going to present today on a non-clonal cause of erythrocytosis, the JAK2 unmutated erythrocytosis, which is actually more prevalent than polycythemia vera. So we're going to walk through the diagnostic and therapeutic approach to this entity, which is a very vast entity, but I'll try to keep it simple so we don't get lost with all the different diseases. I'll start off with 3 cases that I actually followed in my clinic, and we'll use those cases to review the diagnostic approach to such cases, go through a case of hereditary erythrocytosis, then acquired erythrocytosis, which is fairly common, more common than hereditary for sure, and then idiopathic erythrocytosis, which is another evolving and big entity because despite all the extensive evaluations, a significant proportion of patients, we are unable to identify a particular cause. And then how do we manage such patients? Because everybody gets worried about the hematocrit being above 50, and is there risk for thrombosis associated with these entities? So I'm going to try to cover up all these in relation to the different entities and hopefully leave you with some pearls for your clinical practice. So the first case is a 48-year-old Caucasian lady. She was noted to have erythrocytosis while she was undergoing a kidney donor evaluation to donate a kidney for her father. She'd had a history of persistent erythrocytosis. When we looked back at her prior CBCs, even 2 decades prior, her hemoglobin was 19.3, hematocrit was 58. She had hypertension, which was well controlled on lisinopril. She had a family history of erythrocytosis with her mother and brother, both having erythrocytosis and requiring intermittent phlebotomy. And she presented to the hematology clinic with the following hemoglobin hematocrit values. The white count and platelet count were normal. So, of course, in this case, there are several tip-offs, long-standing history, 2 decades prior CBC's documented erythrocytosis, a significant family history suggesting that there could potentially be a hereditary component, and the normal leukocyte and platelet count, no prior thrombosis. So the JAK2 negativity was established at first, and then we went through the diagnostic workup. So I'm going to share this algorithm piecemeal. We'll look through the half, which deals with hereditary entities. So when do we get consults for erythrocytosis? Whenever the hemoglobin and hematocrit values exceed the diagnostic thresholds for polycythemia vera, the referring doctors will usually want an evaluation to make sure it is not masked PV, or we are not missing out a case of PV, because if we miss out PV, we could lead to catastrophic thromboses if they are undermanaged. So hemoglobin hematocrit values above 16.5, 49 for males, and 16 and 48 for females. And these values have to be adjusted for race, for gender, and altitude as well, because we know that at high altitude, you would equilibrate at a higher hemoglobin hematocrit value. Peripheral blood testing for JAK2 exon 12 through 15 mutations should be negative if we are talking about JAK2 negative erythrocytosis. So all these cases that I'm going to be reviewing have been tested for the JAK2 exon 12 through 15 and were negative. So in this patient, there's a long-standing duration over 2 decades. There's a family history with a mother and brother with erythrocytosis. So we are quite suspicious for the hereditary entity. So we start off the diagnostic algorithm on this side. And then we look at the erythropoietin. That's the next step. So if your EPO is subnormal, which is suppressed, then we need to consider the possibility of EPO receptor mutation. And if your EPO is normal or increased, and EPO levels can be highly volatile because it depends on if the patient has undergone phlebotomy or not, which can change the values. So they're not very reliable. But of course, if you find a subnormal value, then you are leading in this path. But if it's normal or increased, then the workup is different. We need to consider in those instances, is there a high oxygen affinity hemoglobinopathy, which is actually the most common cause of hereditary erythrocytosis. For that, we do have a P50 measurement that we can go by. Unfortunately, at the Mayo Clinic, we are no longer testing P50 because there were issues with the assay, but there are some labs in the United States that have it available, and I'm sure it's available in your country. So you may start with the P50 measurement and see where the P50 is at before you further investigate. So if the P50 is below 24, that it is low, then you need to consider the high oxygen affinity hemoglobinopathy. And if that has been ruled out, then other rare entities such as 2,3-BPG deficiency, there's a newly discovered PZIO mutations, which is a very specific scenario when there's iron overload, splenomegaly, hemolysis, and occurs in combination with hereditary xerocytosis. And the methemoglobinemia, those are very rare entities. So first of all, we need to check the P50. If it is below 24, make sure there's no high oxygen affinity hemoglobinopathy. At the Mayo Clinic, we have 3 different testing that we are using to rule out high oxygen affinity hemoglobinopathy, which includes capillary electrophoresis, HPLC, and mass spec. So based on these 3 different testing, if these are all negative, then the possibility of a high oxygen affinity hemoglobinopathy is almost 0. And then we may go to sequencing depending on if any of these results are equivocal, because you can sequence the HBB, HbA1, and HbA2 and see if there is a variant that you identify. If the P50 measurement is above 24 and it's normal and there's no high oxygen affinity hemoglobinopathy, then we consider mutations in the oxygen sensing pathway. And the ones that are well known are the VHL, the CHUASH polycythemia, the HIF2A, and the PHD2. And then there's a newly discovered EPO mutations, which have been discovered in 2018. Those are rare entities, but if all the testing is negative, then we have to get to some of these rarer entities to be able to diagnose our patient. And other considerations are hemochromatosis. Hemochromatosis patients will often have a generous hemoglobin and hematocrit. Ferritin levels may be high, and it's easy to get testing done for that. And it is associated with alterations in iron metabolism through hepcidin. And then in children, there's SCL30A8 mutations, 10 mutations that have been seen in association with increased magnesium levels, liver cirrhosis, Parkinsonism, but those are very rare. So the basic framework is to start with the history, look at historical blood counts, look at the family history, then go on to the EPO levels, and then go down the diagnostic algorithms accordingly. So I'll move on to our patient. Our patient, the EPO level was 1.1, so it was subnormal. The normal reference range in our lab is 2.6 to 18.5. And the EPO receptor mutation screen did reveal a heterozygous mutation in exon 8. And it kind of went with the autosomal dominant pattern, with 2 family members having hereditary erythrocytosis, which was long-standing. So then we had to counsel the patient as to what these findings meant. Is there an increased risk for thrombosis? And we recommended optimal hypertension control with lisinopril, low-dose aspirin, which is reasonable in the presence of a cardiovascular risk factor. And routine phlebotomy was not recommended because patients with EPO receptor mutations are generally asymptomatic and there is not a clearly increased risk of a cardiovascular disease, and it does not necessarily correlate with hemoglobin hematocrit levels. However, before the kidney donation, we did not think it was a bad idea to do a one-time phlebotomy just to kind of bring the hematocrit a little bit lower, even though it is not guided by a hard evidence, but it actually makes each one of us feel better if the hematocrit values are lower prior to a procedure or a surgery. Then moving on to my second patient. This is a 17-year-old Caucasian gentleman, a high school student from Missouri who was referred for unexplained erythrocytosis. He came to the clinic accompanied by his parents. He had myelofibrosis symptoms and was barely able to attend school. GI symptoms, headaches, temperature dysregulation, numbness, tingling, increased sweating, palpitations, itching, and was very concerning because he is a young patient who had emergency department visits for unexplained abdominal pain and a whole lot of unexplained things. But the only thing that they found on his blood work was elevation in hemoglobin and hematocrit, and hence he was referred to hematology. He's a non-smoker without any illicit drug or hormone use. Family history was unremarkable. Physical examination did not reveal any findings. And when we looked at his serial blood counts, he'd had consistent elevation in his hemoglobin hematocrit, which was above the WHO-defined thresholds. So at peak hemoglobin hematocrit was 18.3 and 52.4, normal white count and platelet count. And EPO levels were 22.6, so slightly up, and so it was inappropriate for the degree of hemoglobin and hematocrit. So in this case, of course, he was a younger patient, so we did check for hereditary erythrocytosis abnormalities, and all of those were negative. So kind of completed this part of the algorithm. So our main suspicion in his case was for an acquired cause, and going by looking through the acquired erythrocytosis causes, there are many different causes, and it is an internist disease essentially, but often these patients will come to hematology without having had a full exhaustive internal medicine workup. So we kind of divide it into, is the EPO level significantly increased? If that is the case, then we get suspicious for a paraneoplastic cause, like is there an EPO producing tumor? Specifically, is there a renal cell cancer? Because that has traditionally been associated with high EPO levels. Cerebellar hemangioblastomas, pheochromocytomas was a consideration given his myelofibrosis symptoms, specifically his palpitations, hyperhidrosis. Then in female patients, the uterine leiomyoma should not be under-recognized, specifically because they may not have such a high hemoglobin hematocrit, which may be masked because they're losing through the menstrual losses. So the hemoglobin hematocrit actually may not even exceed the threshold. So that may be more of a masked erythrocytosis entity. And then renal artery stenosis, specifically if a patient has uncontrolled hypertension, renal cysts such as polycystic kidney disease, and then the post-transplant renal transplant erythrocytosis, you would have had a history of a renal transplant. So that doesn't apply to this patient. And then for the other half of this algorithm, if the EPO levels are compensated, normal, or increased, such as in our patient, we worry about hypoxia-related causes. Is there cardiopulmonary disease? Is there obstructive sleep apnea? Is he a smoker? And then drugs. So we want to look through the whole medication list. Is the patient on anabolic steroids? Are they using any kind of testosterone preparations, EPO doping? And then the use of the SGLT inhibitors, and I will cover that in more detail because they are being widely prescribed now for numerous medical indications. And then we always make sure that this is not a spurious value, like this is not dehydration causing hemoconcentration, but if you've had serial evaluations with in a non-fasting state, that should eliminate that possibility. And the rare considerations I kind of put in the bottom of this slide is Is there an SH2B3 link mutation, which is rare, but EPO levels are usually low in that case, not increased or normal? And then the Tempe syndrome, in which EPO is up, that is another very rare entity. But if we don't look at all the associations, we would be missing these. And Poem syndrome is also in this list. But I kind of put them at the bottom is because it's not top of the list. I think the main things in the majority of the medical patients are to make sure there's no hypoxia-related cause, there is no paraneoplastic cause. So we did a very extensive workup for our patient. We started with PAN imaging, ABG, overnight oximetry, checked an echo, urinary catecholamines, metanephrines, everything was unremarkable. And we also went to the extent of checking a bone marrow biopsy just to make sure there were no features of an MPN, even though it was JAK2 exon 12 through 15 negative. So given his neurological symptoms of headaches, nausea, vomiting, we did end up with brain imaging. And the patient was found to have these numerous cerebral hemangiomas and multiple venous abnormalities. We referred him for neurology and neurosurgery, but unfortunately, because of the location of these abnormalities, a surgical intervention was not deemed feasible, and we could not directly prove the causality that these were producing excessive EPO, but these hemangiomas have been associated with increased EPO production and erythrocytosis. The patient started phlebotomies, which improved his symptoms, and he became functional, was able to start college, and the periodic need for phlebotomies was determined by symptoms rather than a particular hematocrit value. So the patient has done well over the years. I've followed him almost for 4 years now, and he is graduated from college, is working, and his hemoglobin and hematocrit are controlled with the need for periodic phlebotomies because he does get symptomatic when the hematocrit goes above 45. So going on to our third patient, 66-year-old lady with asthma, some anxiety, hypertension, was referred for evaluation of erythrocytosis, hemoglobin hematocrit 19.358, and has had a progressive rise in hemoglobin, specifically if you look at her counts over the last several years. Family history is unremarkable, non-smoker, no thromboses or pruritus or symptoms of PV. She is symptomatic with severe headaches and fatigue. And the physical examination had hypertension, but there was no other findings that were noted. So this is a more tricky case because it was hard to kind of know which part of the algorithm she kind of fit under because we don't have the full historical counts. So we did make sure there was no hereditary erythrocytosis because there's a panel, you can just run that and you can rule that possibility. And then, of course, our focus once again was on acquired or unknown duration causes, looking at hypoxia-induced causes. Is there a paraneoplastic reason for it? Is there a renal artery stenosis, particularly with uncontrolled hypertension? Is there renal cysts? And then we kind of went through the systematic workup. And this is what we found. EPO level was actually normal, so it's kind of compensated normal at 13.9, because if your hemoglobin and hematocrit is high, it should technically be on the lower side. Bone marrow was done. There was no features of MPN. Abdominal ultrasound did not reveal any cysts or other lesions or renal artery stenosis on Doppler exam. CT head was negative. Sleep apnea was excluded. We checked monoclonal protein studies, pheochromocytoma evaluation. All were unrevealing. Hereditary erythrocytosis workup was negative, as I alluded to earlier. So we ran an expanded NGS panel because we were not able to explain the reason for the high hemoglobin hematocrit. This panel was recently launched in March of this year at the Mayo. Basically, as the field is evolving with more molecular testing available, we're able to identify a few of the rarer entities. Like this panel includes ACO1, which is iron responsive element protein, and then it has EPO, it has HIF, it has full JAK2 sequencing, PIZO1. So it is actually a more comprehensive panel than the one that we were running in the past, and we were not able to identify any VUS or any pathogenic variant in this patient. So the working diagnosis was idiopathic erythrocytosis or erythrocytosis not otherwise specified. And that's always keeps the patient and the physician a little uncomfortable because we always feel like we might be missing something which is not yet known. So in this case, we recommended aspirin, given her history of hypertension, so cardiovascular risk factor, and phlebotomy for symptoms because she did have symptoms of headaches and fatigue. And that helped her symptomatically. And over time, she has been doing well, actually, with improvement in her hemoglobin and hematocrit values. And on last follow-up, 2 years later, she's not needing any further phlebotomies, which is actually interesting. So the erythrocytosis appears to have kind of self-corrected or resolved on its own. So just kind of put this slide here to kind of go through some of the discoveries in relation to the study of erythrocytosis. This field is evolving. A significant proportion of cases, about 70% of the patients may be undiagnosed, in the sense that we don't know what is causing it, but unless we investigate further, it will be difficult to characterize them. So the EPO was isolated in 1985, so we've come a long way. The EPO receptor mutations discovered in 1993, followed by the VHL in the Russian area of Chuvash, the Chuvash polycythemia, and then the JAK2 mutation, as this audience is familiar with, in 2005. And then in 2006, the PHD2 mutations, because these are all involved in the oxygen sensing pathway, particularly the VHL, the PHD, and then the HIF mutations were not discovered until 2008. And then in 2010, we had the link SH2B3 mutations, and most recently in 2018, mutations in the EPO gene itself have been discovered, which lead to a gain of function, and there's an increased production of EPO actually through the liver rather than the kidneys. And these are rare entities, but unless we think about them and go through the systematic workup, we will not be able to diagnose these patients. So I think this is, for this evening's lecture, this is the most important slide, is basically to take home the message that the workup of JAK2 negative erythrocytosis is exhaustive. One has to kind of go through it very systematically, seeing where is the patient at, what is the EPO level, is this a long-standing history, is this something that is acquired, and then kind of go through the checklist and basically do an internist workup for these patients, specifically in cases of acquired erythrocytosis, because they're not going to be manifest that easily. We have to look through the medication list, take an extensive review of systems to be able to identify and point in the direction of testing. But the bare minimum testing should include overnight oximetry to rule out obstructive sleep apnea, abdominal imaging, abdominal ultrasound to make sure there's no renal or hepatic lesions. So that is the bare minimum investigation for acquired causes of erythrocytosis. And for the hereditary ones, I think checking for the high oxygen affinity hemoglobinopathy should be the highest priority, particularly if EPO is not suppressed, and then going through the germline oxygen sensing pathway mutations. And of course, this field there's going to be more and more discovered, and as the literature gets updated, even for the high oxygen affinity hemoglobinopathies, about 100 high oxygen affinity variants have been described in the database. But as we see patients and we get better characterization, the list is growing over time. So a brief study on high oxygen affinity hemoglobinopathy. These are the most common forms of hereditary erythrocytosis, but yet at the same time, they are rare. So 41 cases of high oxygen affinity hemoglobinopathy have been followed at the Mayo over decades. And the lab has tested over 1,000 patients for these variants and identified only about 100 with the abnormalities. So even when we send testing for hereditary erythrocytosis, there's only about less than 5% of patients that will end up having an abnormality. But without testing for it, we would be missing the patients that would have potentially carry the abnormality. So among these patients, we wanted to follow how does treatment impact their disease course, like particularly the risk for thrombosis and the symptom management. So thrombosis was identified in about 10 of these patients over the course of their follow-up, which was over decades. And we were able to show that the hemoglobin hematocrit values and the treatments that were given to these patients did not necessarily improve the thrombosis risk. In fact, the majority of the patients who had thrombosis were elderly male patients with cardiovascular risk factors, and 6 of the events were arterial thrombotic events, which we typically find in that population. And with respect to symptoms, it's interesting that over half of these patients did have some form of symptom, either headache, fatigue, lightheadedness, paresthesia, syncope, and they were on phlebotomy. And the phlebotomy did help half of the patients with symptoms, but in about 30% of them, the phlebotomy led to other symptoms related to iron deficiency. So the role of phlebotomy is not very clear-cut in patients with high oxygen affinity hemoglobinopathy, and physiologically, they need a higher hemoglobin and hematocrit to be able to transport oxygen to all the organs. So it is a physiological phenomena And aggressive hematocrit control may actually prove to be detrimental to these patients. They may worsen the tissue hypoxia and may actually lead to a vicious cycle, which may lead to an increased stimulus for more HIF and EPO production, and hence further increase in the hemoglobin and hematocrit. And the iron deficiency itself can also be a stimulus for increased EPO and increased hemoglobin hematocrit production. So the take-home message from this study was that we should do an individualized management and refrain from just prescribing phlebotomy for all patients just based on the hemoglobin and hematocrit values, and not use the hemoglobin and hematocrit values as a cutoff, use the symptoms and titrate the phlebotomies to the symptoms rather than a target cutoff like we have in PV, which is 45, and which would definitely be very aggressive for patients with your physiological increase in hemoglobin and hematocrit. So moving on to patients with germline oxygen sensing pathway mutations, by that PHD2, HIF, and VHL mutations, these are even more rare. So we had 41 patients over these decades with HOA, but we had only 10 patients identified, Mayo Clinic patients identified over the decades with the pathogenic variants in the oxygen sensing pathway. And once again, for these patients, we tabulated the thrombosis and identified that 3 of the 6 patients with HIF pathogenic variants did have thrombotic events, arterial thrombosis. Majority of these were, once again, patients with cardiovascular risk factors. They were already on phlebotomy and they were taking the aspirin. So despite that, they did have events suggesting that it was not merely the hematocrit or hemoglobin levels or the phlebotomy that ameliorates their risk for thrombosis, and there may be other factors such as increased in VEGF. And this has also been described in other series where they found that patients with HIF pathogenic variants have an increased risk for thrombosis as opposed to HIF wild type, and the phlebotomy did not appear to reduce the risk. And for HIF variants, it is also important to note that these patients can have other neuroendocrine tumors. So if the patients have any symptoms suggestive of that, we should do directed imaging, but none of the 6 patients in our series had any evidence of a neuroendocrine tumor. And what are some of the other treatments? So there's a HIF2 inhibitor, belzutifan, and it is approved for VHL-associated cancers and also recently for advanced renal cell cancer, it was FDA approved. So this is a case that was actually published in the NEJM a few years ago, where they gave this HIF inhibitor to a patient with the Passac-Zouang syndrome. Basically, this patient had erythrocytosis and had a paraganglionoma. And here you can see with the start of treatment, there was improvement in the norepinephrine and chromogranin levels, and the hemoglobin and the EPO levels also kind of stabilized after starting the medication. And they saw that the tumor mass also regressed with treatment, suggesting that there could be a role for agents such as HIF2 inhibitors in patients with HIF2-mediated increase in hemoglobin and hematocrit. And then what about CHU-ASH polycythemia? CHU-ASH polycythemia is specific for certain regions of the world. It was discovered in the Croatian region and then in parts of Italy. There is a particular VHL mutation that occurs in these patients, which is different from the VHL syndrome, suggesting that it also depends on the location of the mutation, and that may have a differential impact on the phenotype of the patient. So in patients with CHU-ASH, they had increased risk for thrombosis, they have early mortality, and they compared these patients to age and sex match controls, and even with PV patients, and they found that these patients, despite phlebotomy, they tend to get thrombosis. So even aspirin and phlebotomy is not sufficient for these patients. So that is important to realize that even HIF-mediated disease, CHU-ASH polycythemia, the phlebotomy, even if we are aggressive with the hematocrit control, will not necessarily lead to a reduced risk for thrombosis. So managing their cardiovascular risk factors may be a better thing for these patients, because most of these events are actually arterial events. So they gave Ruxolitinib to 3 patients with CHU-ASH polycythemia, and this was also published in the NEJM a few years ago, and they found that there was improvement in the hemoglobin and hematocrit and blood counts and phlebotomy requirements. But what this study does not show is whether there was an improvement in thrombosis risk. I guess their follow-up was not long enough to suggest that. So the impact on mortality and thrombosis was not seen with the JAK inhibitor Ruxolitinib, but just brought this to light to show you that there are treatment approaches for each of these entities that are being looked at. So I'm going to move on to the SGLT related or associated erythrocytosis. And I think that is a very important entity for the hematologists and the internists, the nephrologists, endocrinologists, and cardiologists, since these drugs are being ubiquitously prescribed. So these are also known as gliflozins. Indications are type 2 diabetes mellitus, but has had recent approval for heart failure and chronic kidney disease with or without diabetes mellitus. Hence, there is a significant number of patients who get started on these drugs, the hemoglobin hematocrit goes up, and they get referred to hematology. So we reported this entity of the JAK2 wild-type erythrocytosis associated with SGLT inhibitors a few years ago. We had seen 30 patients, the majority were males. They had hemoglobin and hematocrit levels that exceeded the WHO thresholds for PV diagnosis. The peak hemoglobin reached 17.9, and there was a patient who went up to 19.8. Similarly, with the peak hematocrit, a patient went up to 60.1, and the increase in hematocrit was median was 7.4, but it was as high as 14.1, suggesting that these patients can have a substantial increase in hemoglobin and hematocrit values, which makes everyone uncomfortable. And the interesting part is that this is all drug dependent. We were able to show a dose-dependent phenomena as well, but that was for some of the agents and not for all of them, because there's certain, these patients had received either canagliflozin, appr, or dapagliflozin. And erythrocytosis resolved in 6 out of the 6 patients who discontinued treatment and whose CBC data was available. Since this was retrospectively obtained, all the patients did not have CBC data available at the required time points. It is also important to note that the baseline hemoglobin for these patients was within the normal range. So this is likely to occur in patients who are already within the normal range and they can get tipped over. So we recently expanded this observation to 100 consecutive patients that were seen. And once again, median age is in the 60s. That's the patient population that would typically be prescribed these drugs. 78% are males. And once again, the 16 patients who discontinued treatment, erythrocytosis resolved. And then I highlight how these patients were managed in different ways. So a third of patients actually underwent either phlebotomy or blood donation at the advice of their physicians. Antiplatelet therapy was used in 2/3 of the patients, as we would expect. Anticoagulation in 16 patients, and that was more for AFib or any other indication rather than for the erythrocytosis. And there were 10 patients who had thromboses. And we did not really find like a direct correlation between the hemoglobin and hematocrit and thrombotic events in this entity as well, suggesting that the erythrocytosis in these patients is once again also a physiological phenomena, and it has been correlated with cardioprotective benefits. So it is not necessarily a bad thing, and we may not necessarily need phlebotomy to manage these patients. You could also consider dialing down the dose because it is a dose-dependent phenomena. So if your patient is on empagliflozin 25, we could consider going down to 10 milligrams and seeing if the hemoglobin and hematocrit are at a reasonable range. They may still be above the normal range. And then treatment discontinuation is typically not advised, particularly if patients are going to have more long-term cardiovascular benefits, renal benefits, and just for the erythrocytosis, we typically don't advise that. But if there is any other reason to discontinue treatment, then definitely those are the reasons. The erythrocytosis led to treatment discontinuation only in about 2-3 patients. So what is important to be cognizant of is that when a patient starts SGLT2 inhibitor therapy, and if they have a normal hemoglobin and hematocrit, it may be difficult to know if they have an underlying MPN. So here in our series, we were able to see that in 9 patients, starting the treatment led to an unmasking of the MPN. That means the hemoglobin hematocrit exceeded the PV thresholds, JAK2 testing was obtained, and they were identified to have PV. And interestingly, what happened in the course of these patients, the one I've highlighted here is 3 of these 9 patients had 4 thrombotic events, because the erythrocytosis was not recognized as being due to a myeloproliferative neoplasm, suggesting that it is not a bad idea to consider obtaining JAK2 testing, specifically if your patient has a hemoglobin hematocrit level, which is kind of on the generous side. So what we recommend is if your patient has iron deficiency, leukocytosis, thrombocytosis, or any kind of thrombosis history, or suggestion that there may be an inherent MPN such as MAS PV, the peripheral blood testing for the JAK2 MPL CALR should be obtained. And if they are JAK2 negative, I think it is reasonable to continue the SGLT inhibitor, as I previously alluded to, that is not necessarily an indication to discontinue treatment. So how do we manage patients with JAK2 unmutated erythrocytosis? So this is very tricky because we discuss so many different entities and the management for each one of them may be a little bit distinct, but there are some general principles. So the general principles is the patient symptomatic? Are there any symptoms which can be non-specific as well? They can have headache, dizziness, chest pain, shortness of breath, which may be correlated to the increased hemoglobin hematocrit. So how to manage those patients is consider phlebotomy and see if it directly improves their symptoms. If it does not improve symptoms, we do not recommend continuing phlebotomy for these patients. But if it does lead to symptom control, then the phlebotomy can be done and titrated according to symptom control rather than a hematocrit value. And if the patient has no symptoms or no thrombosis history, there is no reason to do phlebotomy just to keep the hemoglobin hematocrit within the normal range. As we discussed, several of these entities are physiological, particularly patients with COPD, cardiopulmonary disease, high oxygen affinity hemoglobinopathy variants. They need the higher hemoglobin hematocrit to provide tissue oxygenation. So reducing the hemoglobin hematocrit could be detrimental in those cases. Avoid cytoreductive therapy. There is no reason to put these patients on Hydrea or any other agents, not to manage like PV. Cardiovascular risk factor modification is important for these patients because the majority of these patients did experience arterial thrombosis. And for arterial thrombosis, we know the risk factors are age, male gender, diabetes, hypertension. So those can be easily modified. Low-dose aspirin, if there is cardiovascular risk factors. Recommend cessation of smoking if they are smokers, oxygen supplementation for COPD patients, treat the sleep apnea with CPAP. And if the patient is on testosterone or any kind of anabolic steroids, then we need to hold treatment or down titrate it. Specifically for testosterone we usually recommend a hematocrit below 50 before continuing the patient on testosterone. And for SGLT inhibitors, it is reasonable to continue treatment in most cases. But of course, it has to be looked at in a case-by-case basis. And for post-renal transplant erythrocytosis, the use of ACE inhibitors and ARBs has really reduced the incidence. So we don't see a whole lot of referrals for that. But in case the patient has that, then we need to make sure that they're on ACE inhibitor or ARB, and you may not necessarily need to do phlebotomy for those patients. If there is a thrombosis history, then for arterial thrombosis, low-dose aspirin. For venous thrombosis, they would need to be on anticoagulation. But cytoreductive therapy is not recommended. A prophylactic phlebotomy is not recommended in the absence of symptoms. And basically, what this kind of leaves us with is that the management has to be highly individualized. If they're going to have a surgery, that always becomes a very difficult situation. You get referred a COPD patient whose hematocrit is 58, and they're going to have some procedure, and they want to send the patient to hematology to make sure it's okay to have the procedure. And it is tricky. So I think phlebotomizing them can be detrimental because they need the higher hemoglobin and hematocrit, because usually I let them ride. There are some guidelines which suggest maintaining hematocrit below 52 or 50, but there is no hard evidence for those guidelines either. So I think it has to kind of be used on a case-by-case basis. So the take-home message for today's lecture is the JAK2 unmutated erythrocytosis is an evolving area, and there is an increased prevalence, particularly as more and more entities get recognized. The recent discoveries over the last 5 years have been the EPO mutation, there have been novel mutations in the PHD2 VHL genes, and the PIZO mutations. These are rare, only in about 4% of patients with idiopathic erythrocytosis, but if we don't look for them, we won't find them. The PIZO is marked by the P50 being less than 24, so almost like the shift of the oxygen dissociation curve would make you think, specifically if there is no high oxygen affinity variant present. There are expanded and highly sensitive NGS tests in development. We did launch a panel several months ago for idiopathic erythrocytosis cases. Hopefully, we'll be able to identify more variants and be able to do some functional studies to see if those variants really have any kind of clinical relevance. And management for these patients should be highly individualized. For phlebotomy reserved for symptom control rather than hematocrit values. And then the use of medications such as the HIF2 inhibitors, Ruxolitinib, mechanistically it appears enticing, but it does require further investigation because we don't know if it is leading to any improvement in the hard endpoints such as thrombosis and survival. So I am going to stop here with a reference, and this is a very important reference because my whole lecture was taken from this paper we put together earlier this year. It is free access, so it should be available to everyone, even in India. I know I get a lot of requests for things that are under a payment, and this has all the algorithms and my lecture material, and I'm happy to take questions at this point.
Thank you, Dr. Nazima Gangat, for a wonderful and excellent lecture. It was superb and fantastic. You covered almost everything, and what a lecture it was. Thank you so much for being with us. And I now request all our discussants to please put the raise hand sign so that we can start our question answer session with Dr. Nazima Gangat. So, Dr. Nazima, if you can stop sharing your screen, please.
Let's see. Let's see. I think my whole thing got messed up. Let's see.
Yes. Thank you.
Okay. Better now. Thank you.
So first we have with us Dr. Upendra Sharma. Your question, please.
Thanks, Dr. Nazima, for that wonderful talk. I learned a lot from your talk. So, regarding idiopathic erythrocytosis, so what is the evidence for using aspirin in those subset of patients? Because we know that these patients are not at risk of thrombosis.
So there is no evidence, but we use our common sense, right? You want to make sure if your patient has cardiovascular risk factors, if they're diabetic, hypertension, so at least we modify those. And a low-dose aspirin is kind of advice for those patients regardless, right? There is data to suggest that. So I don't think we have any direct evidence, but it cannot hurt the patient.
My second question regarding these patients of idiopathic erythrocytosis, sometimes we have, not sometimes, many of these patients we diagnose as idiopathic erythrocytosis. So sometimes they have high hematocrit and requiring phlebotomies often. And sometimes it is very difficult to have a obese patient with venous access, and phlebotomy are different, are very difficult. So, are there any guidelines to that support that using hydroxyurea or cytoreductive in such subset of patients?
There is no guidelines, and the hydroxyurea was studied in a subset of patients with congenital heart disease. There is a publication, and that showed that, you could bring down the hemoglobin hematocrit levels, but you have to realize that that will have other side effects for the patient, right? And without having a true reason to put them on chemotherapy, I think I would be hesitant to prescribe any cytoreductive therapy just to bring down the hemoglobin hematocrit.
Thank you. Thank you, Dr. Upendra Sharma. Dr. Satish Kumar Anumana, your question, please.
Thank you, Amit. Thank you, Dr. Nazima. Really enjoyed the talk. Very common cases, what we see, you really illustrated very well. So I think one of the question Dr. Upendra asked about ecospirin. So I wanted to ask the opposite question. Are we safe in giving ecospirin to all these high PCV patients when under evaluation, like whether it is hereditary erythrocytosis, hereditary polycythemia, or idiopathic erythrocytosis, or the other young patient you presented with cerebellar hemangioma? Most of them were symptomatic. Even if they're asymptomatic, are we good to keep them on ecospirin, all the polycythemia, all the erythrocytosis cases?
If they don't have cardiovascular risk factors and if they're young, I wouldn't necessarily put them on aspirin. I think aspirin is mainly for patients who do have other reasons to get arterial thrombosis as well. So my 17-year-old patient, I did not put him on aspirin. I just did phlebotomies to kind of keep his hematocrit controlled so that his symptoms got relieved.
Okay, the second question is in cyanotic congenital heart disease. You just touched upon it. There also, do you do phlebotomy based on the symptoms, or do you keep any cutoff hematocrit?
Just based on symptoms. In fact, for congenital heart disease, the hemoglobin hematocrit values are typically very high. You'll have patients who will have hemoglobin of 20, hematocrit of 60, and that's all physiological. So in fact, when you do phlebotomy for those patients, they may actually feel worse, right? And it also precipitates iron deficiency, which can lead to a vicious cycle, and then that can lead to a PhD activation, and then more production of EPO, and then more higher hemoglobin hematocrit. So phlebotomy is not really
when the PCV goes more than 65, they do come with severe headaches and giddiness-like symptoms. Such cases we have done, of course, checking the iron studies and everything. So do you advocate if they're symptomatic for the high PCV? When the PCV is really high, more than 65?
I agree. If they're symptomatic, and if you do the phlebotomy and you document that they improve, then definitely I think it's reasonable to do phlebotomies. And you can always do smaller phlebotomies too. Everybody doesn't need to have 500 cc removed. Sometimes I do like 250, even 200 cc, right? You just want to do enough to kind of ameliorate their symptoms.
Right. The other thing was about androgens. You just touched upon, you said you make sure the PCV is less than 50. If the PCV on treatment increases to more than 50, do you advise decreasing the dose of testosterone and stopping it?
Definitely. I think those Endocrine Society has specific guidelines. So if the hematocrit goes above 50, you do need to either take a pause and then restart with a lower dose and monitor closely.
Amit, just one last question. In post-transplant erythrocytosis, apart from ACE inhibitors or ARB, sometimes the creatinine is high and the nephrologist is not very comfortable starting ACE inhibitors. How do you manage them apart from ecosprin?
There is data for theophylline use. Of course, it's a very old medicine. I've never prescribed it, but there is a publication on the use of theophylline. So if we can look at that, and maybe you can do that, or you can do phlebotomy. It's not like a complete contraindication. If we think that, we're not able to give ACE inhibitor or ARB, then judicious use of phlebotomy can be used as well.
So most of the secondary erythrocytosis, you go by symptoms only for therapeutic phlebotomy. You don't keep a cutoff for any of them, apart from polycythemia vera. You don't keep a cutoff for any of these erythrocytosis, Dr. Naseema?
Exactly. And I think that's the take-home message. Individualized management, and also to use the phlebotomy very sparingly and mainly for symptom control. But we do come into the situation, even though I'm presenting this lecture, there have been times when, somebody is having surgery and we get confused, we get uncomfortable, and we say, okay, it's not a bad idea. Maybe they can have a one-time phlebotomy. So I'm not saying like it's a total no-no, but typically even in the perioperative management, it's best to kind of, do less is more for these patients.
Thank you so much, Dr. Naseema.
Thank you, Dr. Satish. Dr. Sandeep Bartake, your question, please.
Yeah. Thank you, Dr. Naseema, for the wonderful lecture. How do you diagnose Gaze-Box syndrome?
Sorry, I didn't get that. What did you say?
When do you label patient as Gaze-Box syndrome?
That's a stress-induced erythrocytosis. So I haven't had a case myself per se, but it would depend on the clinical situation. I don't think it's a very common syndrome, but it's more that you have to see what clinical situation the patient is in, and then monitor the patient and see if the hemoglobin hematocrit improves after the stressor is removed from that patient situation.
So, but after ruling out all other etiologies, right?
Yes, definitely after ruling out other causes.
The EPO level would be normal in them, or?
The EPO level can be quite variable. So if it's stress-induced erythrocytosis, it might be normal as a compensation, or it could be slightly increased. So I don't think we can go typically by the EPO level. And I haven't really seen a case of Gaze-Box syndrome, but it definitely needs to be considered. But that's typically not like an absolute increase in the hemoglobin hematocrit. It's more like a relative thing. So I would say that it has to be kind of followed and seen if it persists, and then do the full evaluation.
Thank you.
Thank you, Dr. Sandeep. Dr. Reshma, your question, please.
Hello, ma'am. Thanks for this excellent talk. This is the most common clinical dilemma in my clinical practice. So I practice at a place which is higher at altitude, Kashmir, Srinagar. So how do we, you said you have to compensate for the altitude. So how do we compensate for the altitude? Because at least 20% of my patients, which I see in the OPD, are polycythemia, young males, and it hovers between 16.5 to 17.5. And I don't know how much do I need to evaluate them. So how do I compensate for the altitude? Is there a formula? How do we do it?
I'm not aware of a formula, but for patients whose baseline is that, when they come to you, you would be looking at their prior history. So if there's no change if they've always lived in a high altitude, and if they've always lived in Kashmir and that's where they're at, then I don't think you need to do an evaluation for erythrocytosis. So I think I pretty much go by their baseline for their location rather than apply a formula for the altitude.
Okay, so these patients, yes, they live here forever, like they were born here. And these young males usually in, maybe 15 to 25 up to 30 usually come with the hemoglobin which never usually goes beyond 18 or 18.5, somewhere always hovers between this range. So can we just observe them without further evaluation, just document a JAK2 negative, and yes, that's it?
Absolutely, that would be their normal. So that is kind of their norm. So I don't think they would need further evaluation.
Thank you. And the next question is, I have a young female follow-up with VHL mutation. She was basically referred. She had a menorrhagia. CBC was done just to document there is no anemia. Instead, they found a hemoglobin of 18. We did a molecular panel and she was documented as a VLH homozygous mutation. So for her, do I need to use any anticoagulation or aspirin during her pregnancy or in a peripartum period? Will she be at a higher risk of thrombosis?
That's another very interesting question. I think I would use aspirin for her because patients with UASH polycythemia are at an increased risk for thrombosis. So I think a baby aspirin should be a reasonable thing in the absence of course, hard data, because we don't have pregnancy data specifically for patients with UASH.
And without any pregnancy right now, like I'm not giving her any antiplatelets, she just on follow-up. Hemoglobin is controlled because she has menorrhagia. So does she need any aspirin now, or I just can observe?
I think you can observe right now, but during the pregnancy, it cannot hurt her specifically if there's no other contraindication to aspirin use, because we don't know, I don't know of the pregnancy outcomes. These entities are so rare that I don't have a patient with UASH who's had pregnancy, or for that matter, I don't have a patient with UASH that got diagnosed. So I think it's reasonable to observe now and then use the aspirin for pregnancy.
Thank you. Thank you so much.
Thank you, Dr. Nikhil. Dr. Nikhil, your question.
Excellent talk. You comprehensively covered a very confusing clinical presentation. A couple of questions from my side. One is, in these patients who develop both arterial and venous thrombosis, how would you go ahead? Would you give them both anticoagulation and antiplatelet and at both doses? Patients who have had a history of both arterial and venous thrombosis.
So if they've had venous thrombosis, they should be on anticoagulation. I think the anticoagulation we prefer here are the novel agents like Eliquis. I don't know if in India warfarin might be more common. I don't know what the practice there is. And if they can tolerate a baby aspirin, I think it's reasonable to add a baby aspirin too, if there's no like bleeding complications. Of course, they're having epistaxis or there's concern for GI bleed. If it's an elderly patient who's at risk for falls, I would just go with the anticoagulation alone. So you could do Eliquis alone. You could use a prophylactic dose if there's been a remote history of venous thrombosis, and if you check and make sure there's no residual clot left. So there are a couple of ways to go about it, but you could try both as well. So that's not an absolute contraindication to combine both agents.
And if you're adding aspirin, would you reduce the dose of Eliquis? Instead of 5 BD, would you make it 2.5 BD?
Yeah, if we've stopped treating the clot, I think you can go to prophylactic dosing. Yeah.
Okay. And my second question is regarding post-renal transplant erythrocytosis. Patients who are not adequately controlled on ACE inhibitors, ARBs, or those who are symptomatic even after that, when you advise for phlebotomy, would you keep a particular target of hemoglobin hematocrit, or it would be again related to their symptoms?
Related to their symptoms.
Okay. And among those mutations you described, including the NGS and other panels, are there any specific mutations where there is a high risk of thrombosis where you would mandatorily give them low dose aspirin? Are some of the mutations associated with a relatively high risk of thrombotic events among those mutations apart from JAK2 and the known ones?
The UASH polycythemia is associated with increased risk of arterial events. The HIF patients as well. So those are the patients I would probably do like a baby aspirin, specifically if there are cardiovascular risk factors and they're elderly.
Thank you.
Thank you, Dr. Nikhil. Dr. Sanyal, your question.
Hi. Naseema, I have just two questions. So one question is, so I see a lot of patients who came in the health checkup. They're young guys, around 30s, 40s. They don't have any cardiovascular risk factors. Hemoglobin is 17, 18. EPO is low to normal. JAK2 invariably is negative. If you do the marrow, most of them has no features of any MPN. Only one history is that they're a very strong alcoholic, very strong alcoholic. Do you advocate any cause of alcoholism and high hemoglobin?
I have not come across that, but do you think they are hemoconcentrated at the time you check their test? Are they smokers as well or doing other drugs?
So it is very common practice in our country when they have alcohol, they smoke also. They say no to you, but they do, yeah.
Yeah, so I think that might be more of a connection, because with alcoholism directly, I have not come across, but like we said, we're learning, and nobody has referred an alcoholic patient specifically to me for erythrocytosis as of yet.
So my second question is that JAK2 negative polycythemia. So the area is shrinking slowly, or it is still a very relevant diagnosis?
It is slowly shrinking, but it's still a very highly prevalent, because a lot, like I told you, even after the extensive workup, there will be about 70% of patients that are being labeled as idiopathic. So the area is still a very large field, but slowly shrinking, like, the PIZO mutations, the EPO mutations. So we have a few newer entities to explore for, but those are very rare too. So it's like, I would say it's moving at a very slow pace compared to the other fields in hematology.
So when you diagnose as a JAK2 negative polycythemia, so you treat like polycythemia per se, right?
No, we don't treat like polycythemia. If they're JAK2 negative, then they are not polycythemia vera. So that's the message. If somebody is JAK2 exon 12 through 15 negative, then it is a non-clonal cause of. So we should technically not be using the term polycythemia. I think erythrocytosis is a better term, so we don't get confused with PV. And that's the thing. We don't need to maintain the hematocrit below 45. And, you do the phlebotomy just to manage symptoms rather than hematocrit values, and use the aspirin if there are cardiovascular risk factors, and no need for cytoreductive therapy.
So my question is, the hemoglobin is high, EPO is low, JAK2 negative, bone marrow suggestive of MPN. How you rate them? You call them JAK2 negative polycythemia, right?
Not necessarily. If the bone marrow is showing features of MPN, then I would treat like MPN. So even if the EPO was low, there's features of MPN. These are all cases that have no MPN. So I think the focus of my lecture today was on like a non-MPN erythrocytosis, but your case that you're discussing right now, I would treat like MPN, definitely.
Thanks.
Thank you, Dr. Sanyal. Dr. Madhura, your question?
Thank you, ma'am, for a wonderful lecture. I have a question that many a times we come across patients who may not go for extensive evaluation of JAK2 negative erythrocytosis, and we end up relying on some corroboratory evidence, such as looking for unstable hemoglobin, doing an HPLC, or looking for Heinz bodies preparation. Do you think we can rely on these investigations when we are thinking of certain hemoglobinopathies, or should we always evaluate these patients on a molecular level?
I think they have to have the full workup. I don't think we can just rely on, one test. Even for the high oxygen affinity hemoglobinopathy, you start with the P50 if that's available. If that's not available, then we start with the protein methods, the capillary electrophoresis, HPLC or mass spec, and then eventually go to sequencing. So I think just based on 1 or 2 tests is not sufficient. Even our lab, the P50 is no longer available, but they run 3 assays to make sure there's no HOA variant.
Okay. So any other question? Thank you, Dr. Madhura. We have some couple of questions from the audience. So Dr. Heetha B wants to know what is the role of venesection for every patient of secondary erythrocytosis?
We discussed it several times, so I'll kind of reiterate again that the role of venesection is for symptom control rather than an absolute hematocrit value.
Perfect. Another question from Dr. Krishnathan Kannan. Do you always do marrow biopsy before in every patient of JAK2 unmutated erythrocytosis?
A significant proportion of those patients do end up having marrow biopsies because we all feel uncomfortable, right? So it's not a bad idea if it is not absolutely needed, but if you've done the exon 12 through 15 sequencing on the blood and it's negative, if the EPO is normal, then the likelihood that you're going to find an MPN is extremely low. But if your EPO is kind of like subnormal, like one of the cases your colleague just shared, then it may not be a bad idea to check a bone marrow just to rule out the possibility that there's an evolving MPN.
True. Another repeat question from Hita B. Role of antiplatelets in secondary erythrocytosis. I think
The
only
role of antiplatelets is once again based on cardiovascular risk factors rather than just giving every patient a baby aspirin.
Thank you. Another question from Dr. Akash is, can JAK2 negative or JAK2 unmutated erythrocytosis patients can become a blood donor? Because PRU
They
patients
can. Yes, a lot of them, the phlebotomy or blood donation, some of them just donate blood. So they can be blood donor. I wouldn't say they cannot be.
True. Thank you. Another question from Dr. Krishnanatham Kannan. Do you recommend phlebotomy for patients who have sleep apnea syndrome associated with polycythemia?
Not necessarily, because once again, for sleep apnea, the hypoxia itself is physiologically leading to the erythrocytosis. So I wouldn't recommend unless they have a lot of symptoms and we need to control the symptoms. But the main thing would be to make sure they're compliant with their CPAP and are being managed through a sleep center.
Thank you. Another repeat question. Can alcohol abuse cause polycythemia?
I'll have to do some more reading today since it's a repeat question. I'm not directly aware of the correlation, but if they're taking other drugs, like your colleague had mentioned, a lot of them are doing other things besides alcohol. So there could be a reason for that.
Thank you. And another question from Dr. Sandeep Shah. If the patient is asymptomatic, till how much highest limit of hematocrit you will not treat the patient?
That's an interesting one. I think I would be, if they're completely asymptomatic, I don't think I would be worried even if they are like 60, or I haven't had anybody like 70 yet, but 60 or early 60s, I'd be okay with observing.
Thank you. Another question from Dr. Hita B. She wants to know, what is your youngest patient who has got JAK2 positive erythrocytosis?
I only do adults, so my practice could be skewed. So I won't comment on that since I'm not practicing pediatric hemonc. But I think it's been described in children, even though not as frequently as in adults, because the median age for PV is usually 60s. But we do, I'm sure there are some pediatric patients, but I don't have one.
Thank you. And another last question from Dr. Hita B. What percentage of polycythemia vera in your care are JAK2 negative?
What percentage of erythrocytosis are JAK2 negative? Yes. I would say it's almost 80-20, like the erythrocytosis referrals I get in my clinic. The majority are going to be, the vast majority, like 80% or more, are going to be JAK2 negative. So PV is much less common than JAK2 negative erythrocytosis. So there's a whole more erythrocytosis that is JAK2 negative than JAK2 mutated PV.
So I finished all the questions from the audience. Any discussion want to ask any other question for Dr. Nazima Gangat? So I think there are no more raising hands. Dr. Madhura, you raised your hand.
Sorry, sir, I'll just not unraise it.
Thank you. So there are no more questions from the audience, and there are no raising hands. Dr. Nazima Gangat, I may say you're fantastic, awesome. As always, even your first lecture was very good. This was superb and excellent. And what a wonderful discussion. What confidence you have, what knowledge you have. It's amazing. Thank you so much for being with us and spending your time this Saturday for us.
Thank you so much. Have a wonderful holiday season to everybody who attended today. And thank you. It was very enjoyable, especially the discussion is generated by your audience as well. So I've really enjoyed the audience on all the occasions I've been here. So it's a pleasure.
Thank you. Thank you so much once again. Bye. And I thank all our audience and our discussants for joining over here today, and meet you tomorrow at 11:30 a.m. sharp. Thank you. Thanks a lot.